Welcome back to Sleep Part 2. We left off on common sleep disorders and we did talk about insomnia. So I wanted to make sure that this picks up from the last one from Part 1, but I didn't go over irritability and risk factors. Well, I kind of did. I touched on the older age and females, but behavior treatment, stimulus control, cognitive therapy, and also sleep restriction. So excessive daytime sleepiness, you have hypersomnia. Do you ever feel this way? Narcolepsy. I thought I'll bring out this little burp that I researched online regarding narcolepsy for those who were having difficulty in understanding it. Here's a little bit more on narcolepsy. Sleep at night usually begins with sleep onset REM period. Very important to know. This is where dreaming sleep occurs within the first 15 minutes of falling asleep. This is pulled from your chapter reading, but I highlighted what the central nervous system does, stimulants, and also looking here at the different medications that are used to try and help this population. So I want you to pay attention to the different medications. Xanthine, such as caffeine, antidepressants, both older monoamine oxide, MOAs basically, and new serotonin antidepressants are usually unique, effective for controlling cataplexy. Look at this drug here. I want you to look it up and know, I think I have it blocked a little bit. Let me see if I can move it up a little so you can see it, but it's on your page. You can find it on your page. There it is. Provigil. Okay, I need you to look up that drug and know what it is. Okay, and I'm thinking to control excessive daytime sleepiness in narcoleptic clients. So please read that information, and it will be very useful for you in the upcoming events. Always know what's going on in the community and in the public. And I'm sure we heard about date rape drugs before. So sodium oxybate is also known as gamma hydroxybutyrate, or GHB, as one of the drugs frequently associated with date rape drugs. Let's talk about sleep. Let's talk about sleep apnea, frequent short pauses in breathing during sleep, more than 5 episodes. Some patients complain of having a headache in the morning. So, sleep apnea is characterized by frequent short breathing pauses during sleep. Although all individuals have occasional periods of sleep apnea during sleep, more than 5 apneic episodes or 5 breathing pauses longer than 10 seconds per hour is considered abnormal and should be evaluated by a doctor. Here are some symptoms. Please read these. In your book, it talks more in detail of the types of sleep, 3 types of sleep apnea. So I'll show you that as a little blurb and you can read more into it. Talk to your family and friends and coworkers when they do a lot of work and they're not sleeping at night. Let them know about this little blurb here. 19 hours of wakefulness produces equivalent of 0.05 alcohol level, and then 24 hours produces 0.1. That's very significant. It's like we're sending them out and they're under the influence. They're not alert or anything like that. Here is another sleeping disorder, and this PowerPoint is very good and self-explanatory. And more. This I have experienced with others before, being in a patient's room and hearing them grind their teeth. Sometimes they have to put protectors on to help protect their teeth because they're grinding their teeth so much. And some people have periodic limb movement disorder. Some people call it restless leg syndrome, where they can't sleep because their legs are constantly moving. So know that when we're taking care of patients and we're getting their sleep pattern or their sleep history, make sure we ask at the appropriate time. Now, if you have a critical patient coming in, it's definitely not warranted to ask, oh, what is your sleep time and how long do you sleep and how many hours of sleep or do you have any difficulty sleeping? These are critical patients. We can either defer the questions to later or either omit or, or even omit them. After your assessment, which is more detailed than the chapter readings, there are these diagnostic tests. After determining the patient's sleep disorder, then we can formulate some nursing diagnosis: risk for injury, ineffective coping, fatigue, impaired gas exchange, and so forth. Here are some planning or some goals we would like to have for our patient. And here are some of our interventions that we can do: sleep hygiene, client education, supporting bedtime rituals, creating a restful environment, promoting comfort and relaxation, and also sleep medications, if appropriate, which will be ordered by the physician. More of our interventions will be client teaching. These are some here, as well as supporting bedtime rituals, adult bedtime rituals. They like to listen to music, sometimes reading, soothing baths, purring, and so forth. We also need to create a restful environment, like decreasing the noise level. And I spoke about decreasing the noise level, that the lights on the ceiling, some hospitals have them. If it's green, that means that the noise level is good. If it's red, that means the noise level is too high. We want to make sure they're comfortable. The room temperature is not too cold in the room. It's not too hot. It's not too stuffy. The lighting is nice, soft lighting. All these things help promote a restful environment. Here's a little bit more. Here's how we should evaluate using data collected and a desired outcome from planning stage. The nurse judges whether client goals and outcomes have been achieved. So all of our care is we are actually formulating a nursing diagnosis or a nursing care plan or a mini care concept map in our head as we're providing care for patients. Now I want to talk to you, go backwards a little bit and cover some things that I felt that was also important that I did not mention. I wanted to point out this drug, but know that it's very limited availability, okay? I want you to know about the drug, but know that if we had a choice, we wouldn't choose this because we wouldn't be able to get it for the patient. So although the drug is there, it's not really available. I know I went over Provigil earlier, but I wanted to make sure that I talked to you about Ambien, Zolpidem. So Ambien is a sleep medication. We give this medication right before going to bedtime. We don't give it like 4 hours or 2 hours because before bedtime because the onset is really fast. Okay, so maybe like 30 minutes before bedtime would be a good thing. Okay, and then I also wanted you to know about Provigil. It's a medication that is for treatment of narcolepsy. I said that before. Here's the page number if you wanted to read on it. In your chapter reading, it also talk about CPAP. That's continuous positive. Oh, misspelled that. Sorry. Continuous positive airway pressure. Patients use this. Some who do have what we talked about earlier, sleep apnea. So they have a lot of headaches. They wake up. How they end up on a CPAP? They was having sleep apnea. Remember we read on that lasted more than 10 seconds in an hour. And then also sometimes they would wake up with these horrible headaches, like they just wasn't rested, and then they have these headaches. So basically, if you have an apnea, you're not getting that blood and oxygen to your brain, the oxygenated blood, and you end up having a headache. So even if these patients say, oh, I feel better after tonight, I had the CPAP on, they are supposed to use it unless otherwise directed by their physician. As you look at this concept map, I'm not going to really speak on it. I want you just to look at it. And of course, if it's too small, also this is in your book. But I wanted to just do like a little bit of talking to you about knowing the difference and the use or not use of um, things that will help the patient sleep. So we know that music that also helps promote wakefulness. You might think music will make the patient go to sleep, but it actually promotes wakefulness. wakefulness. Television does the same thing also. So, but noise, we want to kind of keep noise to a minimum. Extraneous noises can be blocked by white noise, from like a fan or air. Look at me, I can't type you. From an air or air. I'm sorry, from a fan or air conditioner, or even white noise machine. Those might be helpful as well. Then I want you to also know foods that help promote sleep. You want to give your patients like light carbohydrates. You don't want to give heavy carbohydrates, but light carbohydrates. You want to avoid foods and drinks that will keep the patient awake, like coffee and tea. I think I said this earlier, but I don't believe I said chocolate because caffeine is in chocolate, so therefore it will keep them awake. But you also want to avoid foods that's going to cause like physical problems like indigestion. Like for me, like salsa and spicy snacks. For other folks, that causes indigestion. So we want to make sure that we avoid those things. Sometimes medications that are given for Parkinson's, sometimes the doctors they use them for patients who have that periodic limb movement disorder, PLMD. You can find that in your reading. So I just wanted to let you know that sometimes you go like, this is a Parkinson drug. Why is this patient taking this? Doctors also use it because of its effects for PLMD, which is periodic limb movement disorder. Look it up if you don't know the quite understanding. Now, back rubs are mentioned. I'm so happy in your chapter that it is mentioned. Look on page 1078 where back rubs help. But if the patient refuses it, hey, that's okay. Patient refuses a back rub, you acknowledge them. It's their right to refuse it, but you can also say when I come back, if you like for me to give you a back rub, I'll be happy to do that for you. So acknowledge them and accept if they want something or they do not want it. It's their right. Okay, some patients that have obstructive sleep apnea also, their uvula is all reddened and they have a large soft palate if you really look and do the oral assessment, and a lot of times they are obese. So I think I talked about this earlier. I'm just trying to get everything within this 15 minutes so I don't bore you. The hormone levels and bodily functions. So no different biological functions occur during sleep that becomes altered or lack of sleep. Um, there are studies that indicate errors occur and changes in response times are altered with lack of sleep. So I think I beat this drum enough. Basically, if we don't have enough sleep, there can be errors in our work habits, meaning medication errors, patient errors, things like that that put the patient at risk. Okay. I think I've talked about this earlier in part one, but just know that blood pressure is lowered um, during sleep, and also the heart rate. A lot of people always say respirations, but no, respirations, it is not associated with sleep. I repeat, respirations are not associated with sleep. Okay? Your muscles do relax during sleep, but respirations are not associated with sleep. Let me see what else. I know in part one we talked about the cortisol and sleep, but just know that your cortisol levels fall during sleep. When awake, the cortisol level peaks. Yay! Patient with diabetes who's not getting enough sufficient rest, guess what? The cortisol level will stay elevated, which will impact the control of blood glucose. And that's on page 1066. But I believe I had said that before, but just in case if I missed it, I wanted to point that out to you. Excuse me. And just, I think I said this to you, but on when we talked about our lack of REM sleep, non-REM sleep, I'm sorry, on page 1066, it does cause immunosuppression. It slows tissue repair. It lowers pain tolerance. So we need to have our sleep. It also triggers profound fatigue, increases susceptibility to infection. So we need to make sure we have our non-REM sleep also. Thank you for listening, and hopefully this was helpful to you for chapter 45, sleep.